Placental abruption refers to a premature separation of the placenta from the uterine wall, after the 20th week of gestation and before the 3rd stage of labor. It is a well-known cause of antepartum hemorrhage. The estimated incidence is about 1% of all pregnancies. Maternal conditions associated with placental abruption include preeclampsia and maternal hypertension, up to 50% of cases. Abdominal trauma, especially for anterior placenta. Cocaine abuse. Cigarette smoking. Alcohol use. Advanced maternal age. Patients typically present with painful vaginal bleeding, with board-like abdominal tone. Bleeding can occasionally be concealed, as in a retroplacental hemorrhage. Abruption can occur at various placental locations, including preplacental, subchorionic, or retroplacental. Preplacental abruption is less common than the other types and occurs under the chorionic plate, between the placenta and amniotic fluid. Retroplacental abruption occurs secondary to rupture of decidual arterioles, which result in accumulation of blood between the basal plate of the placenta and the uterine wall. Consequently, the placenta is at risk of basal plate necrosis and villus infarction, with serious adverse pregnancy outcomes. In later stages of gestation, hematomas are of significance if they are large enough to strip more than 50% of the placenta from the myometrium. Subchorionic hematoma results from abruption of the placental margin. This location is preferred for accumulation of hemorrhage, since the placenta is firmly attached to the myometrium, while the membranes are easily separable. Ultrasound is not sensitive for detection of acute or hyperacute placental abruption, especially if the hemorrhage is concealed. Acute hemorrhage is hyperechoic to isoechoic to the placental tissue. Becomes hypoechoic a week after it has occurred, while resolving hematoma appears sonolucent after the 2nd week. Let's see some examples. As we can see on the left side of the screen, acute retroplacental hematoma is isoechoic to the placental tissue. On the other hand, chronic hematoma appears sonolucent on the right side of the screen. Ultrasound features suggestive of placental abruption are retroplacental hematoma, often poorly echogenic, separation and rounding of the placental edge, thickening of the placenta, often to over 5.5 centimeters, thickening of the retroplacental myometrium, disruption in retroplacental circulation, intraamniotic echoes due to intraamniotic hemorrhage, intermembranous clot in twins. Magnetic resonance imaging is highly accurate for the diagnosis of placental abruption, and should be considered when there is high clinical suspicion and ultrasound examination is negative. Potential advantages of MRI include a higher soft tissue contrast, and the ability to depict blood products, which help differentiate blood from other fluid collections.
Complications. Intrauterine growth restriction, particularly when the abruption exceeds 30 to 40% of the placental area. Fetal demise. And maternal exsanguination. Differential diagnosis. A number of conditions can simulate the appearance of placental abruption. For isoechoic hematoma in acute to subacute abruption, on ultrasound consider causes of placentalomegaly and focal myometrial contraction, which is transient. For hypoechoic hematoma on ultrasound consider uterine leiomyoma and purely echogenic subplacental space.